Halle, I'll turn it over to you.
Thank you, Jordan. So yes, I will start with discussion about metoclopramide and CYP2D6. So just providing some background first on metoclopramide use and indications, some of the PK and PGx surrounding that, as well as the FDA guidelines on some of the dosing recommendations, and also going through some literature cases that call out metoclopramide use and adverse toxicities. So first, providing just some general background on metoclopramide. As we may be familiar, it is a serotonin agonist as well as a dopamine receptor antagonist, centrally working in the chemoreceptor trigger zone. So it can be used for a variety of indications, the two of which do have FDA labeled indications for refractory GERD and also gastroparesis. There is quite a few different off-label uses, including bowel obstruction, prophylaxis for chemo-induced nausea and vomiting, dyspepsia, and hiccups. There's also a few other indications that are solely for IV use. Nasal use also common in the palliative care area. Typical dosing is 10 milligrams every 4, 6, up to 8 hours, with a max typically of 60 milligrams in a day, although dependent on the indication. For other indications such as like hiccups, may be lower max dose of about 40 milligrams. Some other dosing considerations are renal function, typical dosing until creatinine clearance is below 60 milliliters per minute, to which the dose may reduce to a 50% of the total daily dose. Further reduction if the creatinine clearance is 10 or lower mils per minute, and that would be a max of up to a third of total daily dosing. However, in these patients, typically would see far less than this, and not many hit that max recommended dose. As far as hepatic function, for those that have moderate or severe impairment, we would also see about that max of a third of the total daily dose at 20 milligrams per day. There's also cautionary for elder adults that this agent is recommended to be avoided. However, if it is warranted that they are needing abuse of it, to start at the very lowest dose of 5 milligrams per dose, and as needed increase with limited use of 12 weeks or less. And then also a person's CYP2D6 phenotype may also impact some dosing recommendations. And that is because metoclopramide is primarily metabolized by CYP2D6 via oxidation. There is, to a lesser extent, some metabolism through CYP3A4 and CYP1A4. However, not as much evidence for recommendations at this time. It's metabolized to an inactive ingredient, or inactive agent. So increase in the CYP function can lead to faster metabolism, whereas decreased function that may be attributable to either a CYP2D6 inhibitor, or maybe the patient also is a poor CYP2D6 metabolizer. That decrease in function can lead to that slower metabolism, increasing that active agent, and possibly increase that risk of adverse toxicities, which include some of the severe ones being CNS depression, which typically can present within about 5 days of use, usually self-limiting. It can resolve within a day of discontinuation of the agent. Most at-risk patients are those that are older, over the age of 65, maybe on other CNS depressants, and also having some kidney impairment. Hyperprolactemia is the other severe adverse toxicity. Typically, that would be seen with prolactin levels 25 to 100 micrograms per liter, but it has been documented of levels being over 200 micrograms per liter as well. And that one can occur within first week of use up to about 4 months of use. So continuing monitoring for that one. And then EPS effects as well. And this one is typically can present within a day's use of metoclopramide up to 12 weeks of therapy. It's associated more with prolonged use or higher doses. It does note that a higher dose would be about 30 to 40 milligrams a day. So it is also not quite at what it could be the recommended maximum dose for some of those indications. This again can be at risk majority for older patients that are 60 years or older, also being on other EPS potentially causing agents such as antipsychotics. And then specifically for acute dystonia, patients that are younger than 30 years of age may be at higher risk for this. Some other just common side effects, drowsiness, hypotension, and tachycardia are pretty apparent with this agent as well. As far as FDA guidelines, it does have a black box warning for tardive dyskinesia, and it also does call out specifically CYP2D6 poor metabolizers, or those that are on concurrent use with CYP2D6 inhibitors. So the two labeled indications there with their dosing, so standard dosing max of either 60 milligrams or 40 milligrams a day with their respective dosing regimens. You can see that those that are poor metabolizer have half of the recommended max dose, and then their maintenance dose also is either lowered by half or even extended by dosing interval. They do list also the typical CYP2D6 inhibitors that we're probably all very familiar with, of the typical quinidine, bupropion, fluoxetine, and paroxetine. And then it does highlight also the evidence as to why these dosing recommendations came about, as those that were on metoclopramide 20 milligrams, while also on fluoxetine 60 milligrams for about a week. We're noticing about a 40 to 90% increase in max concentration of metoclopramide and also the AUC. And again, with their general warnings for serious side effects, their higher doses of 30 to 40 was notated, whereas this was seen in 20 milligrams of use. And again, just a reminder of our CYP2D6 alleles. So we have our normal function alleles, duplications of those normal alleles can lead to increased function. And then we also have specific alleles for decreased function and no function, specifically calling out the star 5 allele, that is a complete gene deletion. And then we see our ranges of phenotypes in these patients. So our ultra rapid are those with our normal alleles with duplications, and our intermediate, our normal metabolizers. We do have that range specifically since our genotypes can range from homozygous normal alleles to also heterozygous with a normal and a decrease, or a normal and a no function allele. Our intermediate metabolizers can also have a variety of range and activity score, either being homozygous with decreased function or having one decrease and one no function allele. And then our poor metabolizers having zero activity with homozygous no function alleles. And then do just want to call out that approximately 5 to 10% of Caucasian ancestry is seen with these poor metabolizers of having no function alleles. As far as literature goes, with seeing some of these cases of patients on metoclopramide and having these adverse toxicities, there was an incidence of a 34-year-old male undergoing CHOP for diffuse large B-cell non-Hodgkin lymphoma. And so they were on doxorubicin, which also can help inhibit CYP2D6. And they were on metoclopramide 10 milligram tablets for nausea. And this patient within the first dose started developing muscle stiffness and tension within intense episodes every 5 minutes. They were diagnosed with acute dystonic reaction, and upon stopping of the metoclopramide and also receiving emergency treatment, the symptoms disappeared as well. They were later genotyped and discovered to be a poor metabolizer of CYP2D6 with homozygous no function alleles. But this was also seen in some pediatric cases as well, 2 of which here are young males, both of Caucasian ancestry. Our first patient was admitted to the hospital having severe muscle spasms as well, fully conscious though, no tongue biting, no urinary retention or anything like that. And it wasn't until they discovered that they had been on metoclopramide 10 milligrams twice a day and also cimetidine 400 milligrams daily for GERD that they realized there may have been an interaction. And then upon later discovery that that patient was also a poor metabolizer of CYP2D6. And then our second patient, very similar. However, they did not have any interaction with CYP2D6 inhibitors, was on a pretty low dose of metoclopramide, 10 milligrams over the counter for gastroenteritis, but also having that stiff neck spasms and abnormal eye movements and abnormal eyelid movements that they were later discovered to be also CYP2D6 poor metabolizers. And so although these patients wouldn't necessarily fit within the standard risk factors of being older individuals or being even having higher doses of metoclopramide, they still were experiencing these very severe adverse toxicities while being on therapy.